Here's a question: can MS cause dementia, memory loss at age 52? And when are antidepressants most successful for people with MS?
So with the first question, yes, MS can have an effect on cognition. It's very uncommon for MS to cause dementia. Of the people that get trouble with memory and learning, it's fewer than 10% who will have significant trouble to the point that they can't do the normal things that they were doing. However, for the 50% of people who do have an effect, it's sort of tough because, sometimes I say to my wife, I think, I walk into the next room, forget what I went in there for. I say, honey, maybe I'm having some trouble. She says, no, you're just getting old, dear. And so it's difficult to know exactly what the effects of aging and the like are, but the kinds of trouble that people have is speed of processing. Often you need extra time, and for younger people that often means making special provisions at school to just take some extra time to do things. Multitasking is basically death to people who are trying to do things with MS. So turn off the email, turn off the radio, try to make sure that the kids are doing their homework, and then focus on what you're doing. And the other issue is, what are the treatments? And it turns out that exercise turns out to be good generally for the body, but also for the brain. So exercise is good for cognition, trying to make sure that there's no other cause of cognitive impairment. We are working, so at Hopkins, we've come up with a pathway that, at least in the animal model of MS, if we treat these animals with specific kinds of drugs that are not available for humans, unfortunately, at this point, we can improve their learning and memory. So the good news is we're working on this and trying to move forward. The second question was about when are antidepressants effective? And the easy answer is they absolutely have no street value for these antidepressants, so they're effective when you're depressed. No one is out there jonesing for Prozac. If you're not depressed, these antidepressants won't have any effect. The 9 symptoms of depression are things that doctors and nurses who treat patients with MS are very good at detecting. It's trouble with sleep, decreased interest, feelings of guilt, low energy, low mood, concentration problems, and again, that's related to the first question. Appetite changes, what's called psychomotor retardation. People are not their bubbly selves, however bubbly they normally are. Some people are more bubbly than others, and then thoughts of death. The last thing, I did get a question that I was handed that I know I'm 100% correct on answering, which is, could I repeat that email, could I repeat the website for that again? So that I can get right, mood, MOOD, 247.com. So I actually could have had each person have a letter here, because we have 11 people, and if you don't have 11 characters, then you don't have it, but it's MOOD247.com.
Someone tested positive on the first test and then negative on 5 tests. What does that mean? Someone who developed antibody and can't take it. When should you use Tysabri? Is it safe to be on the long term? Etc. So what is the current view of Tysabri in our practice and for the patients?
Right, so Tysabri is one of our most effective drugs. I call it the drug that I hate to love, because I love it because it's one of the few drugs that actually makes people feel better, get more energy. Sometimes we see people actually function better, especially if they have a lot of inflammation. The drug is about 92% effective in stopping new lesion formation. So although it hasn't been compared head-to-head with the other drugs, if you just look at the trial results, they're quite impressive. But we all know what happened after it was marketed. The cases of PML started appearing, and it seems to be increasing with time. The other risk factor is prior exposure to any kind of immunosuppression. It appears to double your risk of PML. And then recently, Biogen came out with a blood test to try to manage the risk. And it turns out that if you have antibodies to the virus in your bloodstream, you're still at risk. If you test negative for antibodies in your bloodstream, then the presumption is that you were never infected with the virus, or you have so little in your system that you cannot, that virus can't get into your brain and cause PML. So it's a useful blood test. The problem is that, as with all tests, it's not perfect. So there's about a 3% false negative rate. You can test negative and then check your blood again and test positive. And some people fluctuate around the negativity positivity. And so we do see patients who first time they're negative or they're indeterminate and then they come back positive. There's some interesting data recently that the level of the antibody may have predictive value for your risk of PML. So it makes sense. If you have a lot of antibody, that means you might have a lot of virus in your system and you're more at risk for PML. So there's going to be a presentation and a paper on this that will help guide your healthcare provider to, and you should have your antibody level checked, or what's called the titer. You can actually, as many of you know, have had this blood test done. It's done at one particular site called Quest Laboratories, and if your healthcare provider asks them for the antibody titer level, it appears that if you have an antibody titer level of 0.9 or below, you may be back to the 1 in 1,000 risk, whereas if it's above that, you're probably higher than that, 1 in 200, and if you've been on prior immunosuppression, then it's 1 in 100. So we're starting to learn more about how to manage people with the antibody. It doesn't necessarily mean you're going to get PML, so if you have derived a spectacular benefit from Tysabri and failed every single other drug and you're JC virus antibody positive, I'll have a conversation with my patient and say, well, you've got a 1% chance of getting PML, which is this terrible disease and it can be fatal. On the other hand, if you come off of it, before BG12 came out, we really had no other options, and some people would start having terrible attacks and look like they might be headed for a wheelchair. And so it's a very, that's what I mean by it's a drug that I hate to love, because it's a very difficult decision, and physicians take a Hippocratic oath that we never want to do any harm, do no harm. But in the course of prescribing these drugs, as Les mentioned, there's things that we still don't know. We're not perfect, and so it's important to be very honest about the unknown and the potential for risk as we're trying to help our patients. How this carries forward with the other drugs remains to be seen. There are a couple of cases now of patients converting. They were JC virus antibody positive. After a discussion with their healthcare provider, decided, I don't want to take that risk of PML. I've got young kids or whatever. I just don't want to take the risk of it. And then they switched to another drug. Does having been on Tysabri confer any long-term risk? We really don't know that. There is a case of a patient who 4 months after being off Tysabri and on Gilenya developed PML. Previously, we'd never seen PML in Gilenya patients. So was that brewing beforehand? So in my patients who are switching from Tysabri to another high-risk drug, we're very careful. We use MRIs a lot. One could actually do a spinal tap and measure if there's any virus in the brain. And with BG12, we don't know. The 4 cases that Howard mentioned that were written up in the New England Journal, those were patients who had been on prior drugs associated with PML. They were psoriasis patients, but they'd been on prior high-risk drugs, or 2 of them had very low white blood cell count, so that may be another risk. And so there's a lot of things that one weighs into the equation, and ultimately some of this has to do with your risk-taking threshold.
Thank you very much. I have a couple quick things that I'll do, then we'll keep going around. There's a question, is MS treated with Lisinopril, a high blood pressure drug? The answer is basically no, we don't use that. What can you tell us about Ampyra? Ampyra, A-M-P-Y-R-A, is a pill that helps nerve conduction, and in about 1/3 of people who have trouble with their walking or some other motor function, the Ampyra can help you. The Ampyra can be given with all the other drugs. The main risk is if you've had seizures, then you can't take the Ampyra. But some of our patients do very well on the Ampyra, so you should talk to your doctor about that. Can foot drop be improved by physical therapy? Physical therapy is very important. There's other aspects of physical therapy that can help you with foot drops, so the answer may be yes. Is it safe to stay on antibiotics continually for a recurring infection? In general, we don't like to be on antibiotics continually, but if you need the antibiotics, then you should take them. We generally, if people have don't have urinary symptoms but have infection in the urine, we generally don't like to treat those infections if they're not causing a problem.